In this video, I'll be talking about the sequence that I was taught for clinical examination of the wrist, which may well form the basis of your upper limb intermediate case or short cases in the FRCS Trauma and Orthopaedic section 2. So first thing to say is talk out loud. Always talk out loud so that the examiner can hear what you're doing in your assessment, and so that the patient also knows. And it keeps things a little bit more interactive. You can strike up a bit more of a rapport during the station. Always summarize everything clearly at the end as well. Something I'm terrible at remembering to do, but you must. The first thing with any clinical assessment, of course, given the opportunity, please take a history. The key things you should focus on are, of course, what are the symptoms? With regards to the wrist, it could be pain, it could be a swelling, it could be a limitation in movement or stiffness, for example. So what are the symptoms specifically? Where are the symptoms felt? Can the patient point with one finger to where the symptoms are the most sort of noticeable? How did the symptoms begin? So was this after an event or an injury, for example? When do they experience the symptoms? Is this all the time? Is it at rest? Is it at night? Is it on certain activities? And what are the resulting limitations? Our specialty is all about restoration of function and quality of life. So what is it that the patient is now unable to do? Wrist pain can be sort of from multiple etiologies. Injury, maybe, causes clicking, swelling, activity-related problems. The patient might be able to demonstrate exactly what the problem is and give you the diagnosis. It may be degenerative, so things to give you clues about degenerative conditions: constant aches, slower progression, stiffness, gradual resultant deformities, for example. Could be inflammatory. An inflammatory condition can cause, in addition to the things I've just mentioned, burning or more sort of rest, night pain, and nerve involvement as well. So numbness, pins and needles, that sort of thing. So these are the sort of things to ask about to gain your clues in your history. Always use a common language when you're examining the hand and wrist. I tend to avoid using phrases like, oh, on the lateral side, medial. I tend to say radial and ulnar. So we know that all of this is the radial side, this is the ulnar side. And that doesn't matter if the hand is prone or supine. This is the radial side, this is the ulnar side. Everyone's clear. I tend to avoid things like the first metacarpal, the third metacarpal. I just call them the thumb, index, middle, ring, and little metacarpals. I think it just keeps everyone on the same page and avoids any kind of potential confusion. Right. I digress. Onwards. So in terms of exposure, this is a terrible exposure. Always make sure your patient is properly exposed. Ideally both sides. Always compare both sides. For the purposes of the video, I'm just going to show you here. In terms of the approach in orthopedics, we live by the mantra of look, feel, move. But for the wrist, actually, we're going to say look, move, feel. And essentially, it's an anatomy revision session for you, is how I think of the wrist exam. Remove all jewellery, make sure you've got a nice table or a pillow or something to rest the hand and elbow on, and ensure your patient is comfortable. And so we begin. Start by looking. We're looking for all the usual things: any swelling, any lumps, bumps, wasting, abnormalities, bruising. Ask the patient to show you in pronation and supination. So we've started moving already. But just have a good look around, any kind of clues you can find. After that, we start moving, active and then passive. So palmar flexion, yeah, active then passive. Dorsiflexion, active then passive. Have a look from different angles. Certainly, lumps and bumps, ganglion cysts, etc. might make themselves evident and give you clues during these movements. So in addition to palmar and dorsiflexion, of course, movements at the wrist: ulnar deviation, yeah, radial deviation. So you can get some clues certainly from anything that you might see there. Next, we move on to feel, and this is really the bulk of the examination. I've got this model here just to help with our revision. So start proximal to the ulnar, to the radial styloid. So proximal to the radial styloid, if we're feeling, you can ask the patient to move their thumb as well. We might get symptoms generated from intersection syndrome, for example. If we come to the radial styloid itself, we can feel for tenderness that might be resultant from de Quervain's tenosynovitis. We may feel any ganglion cysts. A provocative test you can perform, of course, for de Quervain's tenosynovitis specifically is the Finkelstein's modified Eickhoff. You ask the patient to flex their thumb in, grab their thumb using their other fingers, and ulnar deviate. And that stretch along that first extensor compartment can generate pain associated with de Quervain's. So from here, from radial styloid, we can slip quite easily into the snuff box. Yeah. So examining the snuff box has to be in ulnar deviation because it just brings everything of the snuff box to the fore. So when we're palpating into the snuff box, you'll feel radial styloid, you drop off onto the scaphoid, into the joint space trapezium, and then your base of thumb, your CMCJ, and your base of the metacarpal there. So all of that radial styloid, you feel it on yourself. Dip in scaphoid, trapezium, and CMCJ, and base of metacarpal there. While you're here, if you're thinking about base of thumb, we can just move slightly volar and move your way along. Feel for the proximal pole of the scaphoid, which, of course, you can feel your FCR to guide you there, and you can work your way up onto STT as well. Provocative maneuvers here, well, you could perform a grind test for base of thumb arthritis. Be careful not to cause your patient too much pain during an examination, certainly, and in clinic. You can test the STT in a bit more detail for osteoarthritis with dart throwers motion. So ask the patient to pretend they're throwing a dart, and that movement will generally provoke the STT if it's pathological in any way. Right, coming back to our palpation. So once we've done base of thumb, we can slip back and more dorsally work our way along. You can feel the radiocarpal joint here, but if we come onto the radius, you can orientate yourself by feeling for Lister's tubercle, which is this bony tubercle just here, around which we know is our third extensor compartment with our EPL tendon running there. You can ask the patient to move their thumb up and down so you can feel the tendon and feel for any potential pain there, any tenosynovitis, for example. If we move our way distally from Lister's tubercle, you'll drop down into the radiocarpal joint, and that's where you've got your scaphoid and the scapholunate interval just there, and scapholunate ligament, in fact. So you can feel for your scapholunate ligament there. Again, you can get the patient to palmar flex a little bit, and any ganglion cysts will certainly make themselves known and much more obvious at that point. In terms of scapholunate ligaments, the provocative test here, you may know the Watson's scaphoid shift test. You technically need both your hands to do this. I'll show you using one. But you position your patient's wrist as such, and what you want to do is take hold of their radius and ulnar with your palm and your fingers like so to stabilize, and your thumb needs to be pushing onto the scaphoid proximal pole, just there. You feel it yourself and just apply that dorsal pressure. And using your other hand, what you're going to do is gently ulnar deviate and radially deviate the hand. So hold, you can feel this on yourself, and you can do it to yourself actually. So press onto your scaphoid proximal pole. Ulnar deviation will cause your scaphoid to extend, and radial deviation will cause it to flex. Now you can feel your scaphoid pushing your thumb forwards. In a scapholunate ligament injury where that's gone, actually keeping that dorsal pressure as you radial deviate means that the scaphoid will sort of clunk dorsally, and just releasing that pressure a little bit with your thumb, you'll feel it go click and sort of come back into a more volar direction. And that gives you a clue about your scapholunate ligament. I think that's probably a bit of digression there again from myself, which is a classic habit of mine in these videos. Right, let's move on. So we've come into here, so scapholunate ligament, ganglion cysts, anything else. And then if we move centrally again, actually, and you ask the patient again to palmar flex, you can feel the lunate here. So you can feel for the lunate, and then if you move across further, you can get to lunar triquetral ligament if there's a ligament injury, for example, or any instability. Going across from there, we can ask the patient to radial deviate, which means that the foveal soft spot for the TFCC becomes more evident. So you can feel into there for any potential TFCC injuries. And then basically from there, sorry, I'm just twisting my hand around so you can hopefully try and see where I'm pressing. It's the foveal soft spot. You can feel along your ulna, you drop off into the joint there, and that's your soft spot to feel TFCC injuries. You can also feel the ulnar styloid, of course, for any pain there, ECU, FCU, and then you're onto pisiform. So if I flip this over, yeah, these are the places that I've been feeling: ulnar styloid, interfoveal soft spot, and then pisiform is just there. Any other provocative tests for the Druge? I suppose you could do piano key sign, where ask the patient to put the hand on the table and try and supinate. So usually, you know, that's the motion that results. If you've got any problems here, piano key means that the distal ulna will ping up and you'll have a sort of kappa ulna type sign. Right, anyway, that is a quick screen for the wrist, taking an approach of look, move, and feel.